Matt Johns. All right, I'm gonna mute myself, and you are good to go.
Okay, so she said,
All right.
can do the same option as last time, 8 sessions with 2 free.
Good to go?
I think so.
Yeah,
That's good.
All right. Well, first and foremost, I want to thank all of you for taking the time to actually sit down and listen to my presentation. I'm sure you all know me by now, but if you don't, hi, my name is Mohammed. I'm a third-year physical therapy student at Rutgers University. And today, I'll be discussing with you the psychological aspects of sports injury and rehab. So, injury is an inherent consequence of athletic participation, impacting not only the physical well-being, but also the psychological well-being of any individual. The way athletes perceive themselves, their self-esteem, their belief system, their values, and even their emotional equilibrium could be jeopardized if not addressed properly. Unfortunately, sports medicine professionals frequently concentrate on the physical injury, neglecting the crucial psychosocial dimension. Athletic injuries can serve as a significant source of stress, anxiety, confusion, and fear, hindering a patient's full recovery and rehab process. Now, the purpose of this PowerPoint is to equip clinicians with practical steps to ensure a comprehensive approach and to facilitate a complete recovery program. Now, Now, in terms of the biopsychosocial model, it's critically important to consider all the factors influencing the patient's pain condition. Anytime we pigeonhole ourselves into any one aspect, whether that be the social aspect, the biological aspect, or even the psychological piece, we're losing sight of the bigger picture. As we understand, pain is subjective and it's experienced differently by each person. Therefore, adopting a biopsychosocial paradigm could help clinicians identify the missing components of therapy and address it. Now, how much of each component varies from person to person, but it's critically important for the providers to look at this model and see where they can intervene. And if you guys have any questions throughout the process, please just let me know. Or you can save it at the end. So there's often the misconception that when you bring psychology into pain, you're doing that because the pain is in the person's head or the pain is not real. Well, some pain conditions are 100% rooted in psychogenic factors. But even if that's the case, the person's pain experience is still a real pain. It's just what's causing it could be something different. Now, this image illustrates the, sorry, I'm moving this. There's really no good way to put this.
Yeah, they can't see that.
Yeah.
Just you.
Yeah. This image illustrates the initiation, the maintenance, and the perception of pain being influenced by the biological, psychological, and movement systems. Pain can stem from damaged tissue, termed nociceptive pain, or it could be from the damage to the system responsible for reporting the damage, which is the nervous system, resulting in neuropathic pain. Now, there's no clear official category for the pain conditions that involve dysfunction of the sensory system or the interpretation of signals, as opposed to tissue damage. And this we know as nociplastic pain. Before I move forward, I want you to imagine driving your car and suddenly the engine light comes on. However, upon thorough examination by the mechanic, they find that all the physical components, so like the engine, the brakes, and even the electrical wiring, is all in tip-top condition. The issue seems to be the sensor system or the interpretation of the signals rather than the actual mechanical problem. This is comparable to nociplastic pain, where there's the perception of pain without the clear evidence of ongoing tissue damage. And now let's shift gears and discuss the athlete's responses to injury. All right, so imagine the scenario of accidentally stubbing your toe into the edge of a table. What's your initial reaction? Mostly frustration and anger, right? Well, now envision being a high-level athlete that just got injured, and your entire identity and self-worth revolve around a sport. Now, you find yourself unable to participate. The emotional impact is profound, leading to a state of shock, denial, and frustration. As the realization sets in, there's a gradual loss of self-identity, given that their daily, monthly, and yearly routine that's linked to the demand of the sport is impacted. In coping with this situation, athletes often develop both healthy and unhealthy coping strategies to alleviate some of that emotional strain. It's not uncommon for them to establish unrealistic goals or expectations, setting themselves up for challenges they can't realistically meet. Upon deciding to return to their sport, there's a prevalent fear of injury that surfaces, accompanied by the accumulation of performance anxiety. These factors in turn exert a significant influence on the patient's intrinsic motivations, affecting the athlete's overall well-being in relationship to the sport they love. And I had to throw Aaron Rodgers in there because, he's relevant. So this image does a good job on encapsulating all of the factors that influence the athlete's initial response to injury and the timeline to recovery. According to this model, injury becomes a new stressor in the patient's life, leading to thoughts, feelings, and actions that affect the athlete's rehab process. Here's a good video that I would like to share with you guys. I'll probably just share like the first 2 minutes.
That's fine.
Because it's a good segue. Are you guys able to hear this one?
This is you. Now, forget the past.
Yes.
Forget your plans. This is now your life. How are you going to work with it? You are not your injury. You have an injury, but don't let it change you into it. When you're injured physically, you get injured emotionally. It changes your lifestyle and therefore your way of thinking. You then have to consider the reality that your life's taken quite a hit. That's hard. Pride can make you and it can break you. Which fate is yours to decide? Are you going to feel sorry for yourself, or are you going to accept that you are going to get through this? Strength is not just physical, it's emotional. It's on multiple different levels, one of which is to be mentally strong. If you can bench 315 pounds, but you can't work through a 2-week injury without falling off your horse, you aren't very strong, are you? Here's the hard part. Are you going to do what's best for you? Forget your routine, forget your plan for the year and all the different decisions that go with it. Forget the person that you were before you got hurt. The things you did for fun, the things you did as a hobby, the things that you did to feel good. You need to start adapting to the who that you are now. The old you is dead. The you from before your injury is dead. That person is gone. The question is, how are you going to rebuild the new you? Are you going to rush your body? The only thing that you really own and value in this world, are you going to rush it back to health? If you rush art, it doesn't end up as a masterpiece. We all know this. Some things just cannot be rushed. There's a process. But if you take your time and you make every brush stroke count, it becomes a masterpiece. The artwork is not a blank canvas as it was before. It's still a canvas. It's just different from the canvas that it used to be. The same thing applies to your body. It's not something that can be rushed into the state it used to be in. It's something that has to go through its process.
Alright, so I'm just gonna stop it there just to not take too much of the time, but really good video. I'm gonna send out the link to the presentation too if you guys can go and watch it at any time. So yeah, that's a great segue into the clinical presentations and interventions that I will discuss with you now. So the negative consequences of injury, not to beat a dead horse, but in general, injury is perceived as a negative life event, and as such, it becomes a major source of stress to patients. And stress is defined as the demands of a situation exceeding the resources to respond to those demands. Research shows that there are more than 20% of D1 athletes that experience general symptoms of depression, and that's not even considering injury. Now, those with moderate to severe injury reported stress, depression, emotional fluctuations, anxiety, anger, and frustration. And as healthcare professionals, we can alleviate anxiety by using psychosocial techniques, such as relaxation, imagery, goal setting, and positive self-talk. Now, Dr. Brett McCabe, a clinical and sports psychologist specializing in D1 athletes, outlines 5 psychological phases of injury rehab. These stages offer insight into the psychological process or psychological journey an athlete undergoes during a recovery process. And I added in some physical therapy implications and interventions that we will be discussing. So, the immediate loss of function, the moment of injury, the immediate response of going from a highly functional individual within a minute to a point where your foot is in the wrong direction and you can barely walk now. So patients will likely present with a lot of pain and discomfort. And as clinicians, it is our job to educate these patients on how to manage their pain. We need to help them understand when is it appropriate to apply modalities like ice or heat, or how to brace themselves to go to sleep, or how to perform self-care, when to shower, when not to shower. If they're taking medicine, when should they take it, or when should they reschedule their PT appointments? That way it's not influencing or impacting their PT performance here in the clinic. And so our goal is to build trust and rapport in this phase, reduce pain, and provide patient education. Now, I had a really interesting conversation with Dr. Joanne, who is a faculty member here at Rowan. She's a sports psychologist, and she provides some good insight that I will share with you.
I think the biggest piece, and I know you've brought this up already in our conversation, is building that rapport and that trust. So I think that's regardless if it's the clinical side or if it's on the psychological, like wherever it is, but they're very vulnerable when they're going through this. And for some, they are away from their family, or they're away from their normal structure, and they're learning to trust in somebody who's basically brand new. For some, it's their first injury that they've ever had, and they don't know what this process is like. So recognizing that they're vulnerable in the moment is important, because we may expect them to be like, well, this is the protocol, why are we not moving forward, right? But why are they stuck, at this? They can't progress from here. Like, what is going on? Are they not resting enough, right? Are they not, allowing themselves to heal? Are they doing stuff they shouldn't be doing, right? Or is it something on another level, like on that psychological level, or just the stress? They're stuck in fight mode and they can't relax. But I think just normalizing the conversations, and yes, they're there for injury rehabilitation, but they're a person, and just chatting about, again, like, how was your weekend? What'd you do? And having those normal conversations.
All right, so I'm just gonna move forward with this, but very good insight, really good conversation. I wish I can post the whole hour that I talked with her, but unfortunately I can't. Unless you go on YouTube and subscribe to my YouTube channel. So now addressing patients' thought patterns. So they start second guessing themselves. They start having really negative self-talk, and they start rewinding the tape on what happened. They would start to say things like, why did this happen to me? I won't ever get back to where I was, or I shouldn't have taken on that play. I hear a lot of people, especially in soccer, they say like, oh, I shouldn't have gone for that tackle. Like, if I didn't go for that tackle, I would have never been injured by now. But it's our job to reframe their thought pattern into productive thoughts. So as clinicians, we can give them talks or one-liners like, we're going to get through this, we're going to build something better. And as a clinician too, if you've seen a certain diagnosis or a certain impairment before, you can say, hey, I've seen this before, and I've seen people in the same position that you are in, and trust me, they've gotten better. So just that reassurance really goes a long way to people that come in here for a very nasty injury. Phase 2, I'm just gonna brush through these. It's fairly similar to phase 1, but now we want them to accept where they are, and what happened, and what they need to do to get better. The goal here is to manage expectations, normalize the condition, and express confidentiality to allow for more comfort. We don't want them to psychologically look ahead and predict the future and what's going on. What we should tell them is what you're doing right now is what we should be focusing on. It's like driving through a thunderstorm. We don't need to turn on the bright lights. We don't need to turn on the radio. We don't need to go on our cell phone. What we need to do right now is eliminate all distractions and focus on the task at hand in order to get out of this phase. Phase 3 is a tricky one because here the ADLs improve, but they fall into the mental trap of thinking that just because they can do a little bit of stuff outside of the clinic now, that they no longer need PT. Well, that's not the case. Therefore, as clinicians, we have to manage their expectations. We have to normalize their progress, and we have to encourage adherence and understand the patient's goals. So it's a very confusing phase for the athletes, and it's our job to help them kind of determine where they want to go from there, especially if they want to go back to sport. And according to the literature, goal setting is the strategy that is most often endorsed by sports psychology and sports medicine professionals. And it's one of the most commonly used psychosocial strategies during injury rehab. Goal setting has been shown to have positive effects on increasing patient motivation and rehab adherence and compliance.
We need to remember that many athletes are very goal-driven. They're very goal-oriented. So when something's taken away from them, they kind of flounder. And it also depends on their athletic identity too. Like someone with a stronger athletic identity now being injured might really just not know who they are, and not know what else in life they enjoy and what they're passionate about. So even thinking about how can you add in that clinical side, like goal setting in sessions could be something for some of these athletes that then they can be like, okay, now I'm more driven and connected to the process.
Yeah, really good insight from Dr. Joanne there. So phase 4, the patient is in the physical functioning phase. We want them to stay level-headed. We need to encourage them to keep going with the process and not overdo anything. We need to establish functional ratings and determine their goals for return to sport. And the goal is, as a clinician, is to chart progress and redirect misperception. And last but not least, return to competition phase. We need to focus on minor progress at this phase. We need to manage fear of re-injury and emphasize playing aggressively. We need to get them in game shape, competition, in the competitive mindset, and have the mental freedom to play without even having to consider their injury. We want a soccer player to go in for a tackle, pop up, and run without even thinking about their knee. We want a basketball player to go for a rebound and drive to the bucket and get a slam dunk without even thinking about it. And so just a quick summary of the physical therapy implications about what I just talked about is: number 1, build trust and rapport; 2, express confidentiality to allow more comfort; keep the patient engaged, especially in that third phase where they're confused; active listening throughout the whole plan of care; manage expectations; and effective communication. I'm just going to expand a little bit more on effective communication here, saying that Injury rehab can be a long process, and it can be difficult to keep athletes motivated and adherent to the duration of treatment. That's why it's important to increase rehab adherence with effective communication skills to educate the patient on the injury and their plan of care. We want them to engage in relaxation exercises to decrease the stress, anxiety related to the injury, and have collaborative goal settings to take advantage into the individual's needs. In an article by Dr. Stewart called "Sticks and Stones: The Impact of Language in Musculoskeletal Rehab," stated that many patients with musculoskeletal conditions are anxious about their future, and they are naturally predisposed to see the negatives rather than the positives. When we are physically and emotionally low, we not only hurt more easily, but we seek information that supports our vulnerabilities. Health professionals need a keen sensitivity to the ways that patients hear their words and how those words can be interpreted. And also, to improve effective communication, you can look at the 4 E's and 2 F's of the biomedical tasks. Here are more questions that you can ask your patient throughout your plan of care. Again, I'll be sending out these this PowerPoint. Other effective interventions are positive self-talk, imagery, relaxation techniques, motivation, and meditation. Now, the juicy spot, research. So 55% of athletes post ACL injury return to competitive sport. So me hearing that number makes me want to boost that number a little bit more, because I'm just saying that we can do a better job of getting patients back into at least competition level. So in a systematic review by Arden et al. Showed that 55% of athletes return to competitive sport post ACL injury or post ACL reconstruction. But the results found through a meta-analysis that symmetrical hopping performance, the contextual factors of younger age, people playing in elite sports and having a positive psychological response favored returning to pre-injury level sport. Here, manual therapy plus effective communication. Clinical trials have shown that pain neuroscience education combined with either exercise or manual therapy is far superior in reducing pain compared to education alone. Here's another systematic review concluding that positive psychological responses had a higher rate of returning to sport. And here's another systematic review by Arden et al. Finding that psychological readiness to return to sport and recreation was the factor most strongly associated with return to pre-injury activity. And here are some return to sport testing that you can do to boost the patient's confidence to going back to sport playing free. And if I could leave you with something, I would leave you with this. So this is a famous research study by Kurt Richer in the 1950s. He was a professor at Johns Hopkins, and he did a famous drowning rat psychology experiment. This experiment, although it was pretty cruel, demonstrated the power of hope and resilience in overcoming difficult situations. Dr. Richer placed rats into buckets of water and timed their ability to swim. Rats who are apparently known for their strong swimming skills lasted an average of 15 minutes before drowning. In a second experiment, Dr. Richer rescued the rats when he saw them begin to stop swimming and sink. When he took them out, he dried them off and gave them a short period of rest. And then just as they were dry and rested, Richer put them back into the water. However, this time Richer identified a substantial behavioral change. The rescued rats swam longer than 15 minutes. In fact, they swam for nearly 60 hours. And now I want you to imagine that patient walking into the clinic with no sense of hope, Now consider the profound impact that you can have as a clinician on that patient. You could have and guide how you can guide them towards the brighter realms of optimism. Picture this transformative journey of rehab under your guidance, where they not only recover fully, but also surpass their previous athletic prowess, emerging to stronger and more resilient than ever before. And I do have case studies, but I don't have any time, so here are my key takeaways, and here are my references. Thank you so much. Open for questions.
Awesome job.
Thank you, thank you.
We got a couple minutes for questions, and then we'll. They're applauding you.
No, thank you.
Let me at least pull up the sound online. Yeah, great job, man. I thought that was awesome. And,
Thank you.
Yeah. What was I gonna say? No, I thought that was very thorough and very well done. It was cool to hear Dr. Bullard's info too, because I hear myself twice. Jeez. I'm glad that you reached out for a little bit of mentorship from her, because she's awesome. But yeah, no, I thought that was very well done. The case studies would have been cool to go over, but we can always look at them individually. The video was good. I liked the analogy at the end with the rats. So you're saying that we should be pushing our students into like pools and seeing how long they last?
Well, I don't know about students, maybe patients.
Okay. So yeah, no, I don't think I have any questions for you, to be honest. I thought that was very well done.
Thank you.
Yeah.
Anyone else? No?
No, I think that was
Yeah.
awesome. I really enjoyed that.
Thank you.
I feel like the only thing I thought of that was a really helpful connection, like the response to injury. This isn't so much a question as a comment, but response to injury and like the way that you have an opportunity for either to be a healthy response versus an unhealthy. I feel like it made me think of conflict, where like you just have a negative association with it. Like we have a negative association with injury,
Yeah.
but like the opportunity for a healthy response versus unhealthy.
Yeah.
I think that was just really well done. Like how do we redirect our patients to have a healthy response to injury?
Yeah. It's all about redirecting the patient's framework, really.
Yeah.
Because it is a negative consequence and a negative event. So we have to really make sure that they can go back.
Yeah.
Feeling positive about what they're going through.
Yeah.
Yeah.
I guess one question I can give you is, how do you feel like in this clinical, have you gotten to see this practically, or like?
Yeah, I was just talking
what
to
was that experience?
Justin, actually. Like before, I never really experienced like the psychological aspects of like rehab before. Like I saw it and I kind of brushed it off, to be honest. But here, because the patients are motivated and they want to get better, but they still have that lingering fear of going back to what they want to do. It's just it kind of stood out to me, and I was like, well, I do want the patients to get better in any kind of sense that I can help, even if it's outside of my scope. Like if there's any resources, I'll give them to help them out. I'll do it. And which led me to thinking about like, well, the mind is a very powerful tool, and mental strength is very, very important. So in order to kind of, yes, you're physically doing well on paper, but what's holding you back? What's that one last thing that's holding you back? And it's just the mental aspect of like fearing of re-injury, or just some patients even, it couldn't be like always logical. It's sometimes like them just having like the self-evaluation of, oh, like I'm going up and down stairs and I'm still having pain. That's showing that I'm still not 100%. But all the return to sport data is showing that they're good, or their single leg hop is showing that they're good. It's just that one self-evaluating thing that they have in their mind that they can't get rid of is still limiting them. So, the further I went along in this, with this clinical field, the more I started to appreciate and respect that more, and the more I started to kind of like, instead of always educating, like, oh no, do this, do that, I started to listen more. I started to kind of understand like where the patient's coming from, and see what they're having trouble with, and kind of just build off of that. So that's been something that's really been like transformative for me in this clinical field. And also Dr. Jeremy said too that I'm guilty of nocebo, where it's the opposite of placebo, where instead of giving like positive affirmations, which I do, I also give negative seeds, or plant some negative thoughts into people's the patient's head, in the sense, oh, like, well, you shouldn't, well, that intervention isn't going to be fully healing you, but like you should feel a little bit better. But I found that I was something I was unaware of, and it brought me, it made me more self-aware of like what I say. Yeah. AJ, question? Or
Yeah, quick question for you, Mel.
Yeah.
I feel like when you play like a unique role in athletes, especially our like, collegiate athletes that we see at Trifecta, how would you personally like help an athlete manage the expectations that other people are putting on them, such as like their coach, their athletic trainer, like their athletic director, on returning to sport?
That's a really good question. Thank you for actually, unmuting and saying that. So it's our role to manage the patient's expectations, and by listening to the patient and hearing where they're coming from, yes, they're gonna have the stressors and the anxiety and the lack of social support from the family about their injury. Yes, like maybe they have a certain expectations that they need to meet, but it's our job to kind of be that, be that escape for them. Like have them talk to us, have them let everything off on the table. Like it's all confidential information. Once you listen to them and once you gain rapport with them, you're able to kind of little by little give them the patient educational pieces to kind of start getting out of that framework where you're performing up to your expectations. You shouldn't follow anyone else's story. This is your story. So yeah, you're going through an injury right now, but what you need to do is focus on yourself first. Forget all the expectations that are set on you. Leave that chip over your shoulder, leave it away, and just focus on getting better. And hopefully with your rapport, with your education, and with the trust that you build and the journey that you have, you're able to get that patient into a better mind frame and an even better physical aspect.
Awesome, thank you.
Yeah.
I think that was really well said, Mel.
Thank you.
I feel like the part that gets challenging. Can you guys hear me still?
Yeah.
The part where it can be challenging sometimes is, like you said, it's important to build our rapport, but if we don't build strong enough rapport, we just haven't had enough time with the patient yet, and you're not that highest priority on the totem pole, and they're getting all this other stuff from other people, that's where we got to be tactful with how we deliver things, because if they trust, their coach or someone more than you, and we give, too strong of education too soon, it might even turn them off. But I agree with everything you said, and that's where, like you mentioned, the adherence stuff, as they get more functional, they're feeling better, but they still have deficits. I think something I've been mentored with that's helped me keep them, along with the communication, is forecasting, what goals are coming next, what big landmarks in their rehab are coming, to where, it keeps giving them, kind of like Dr. Bullard said, that those goals and those kind of intrinsically motivating things to keep coming and keep working on PT. And then I just shared the screen. Can you guys see the screen?
No, I think we're good.
Oh, yeah. Really? Try and stop sharing yours. I just used a cool picture that I took from the Therapeutic Neuroscience Education book.
There it
is really kind of helpful. Do you guys see it now?
Yeah.
So I thought this is just a really cool diagram because it helped me kind of see. It's like we have much more of an impact on people's trajectories in their life, I feel like, than we kind of give ourselves credit for sometimes. Just because, if someone gets injured, there's that pain experience. It's like you go two different trajectories depending on, how that person responds to it, which is like what you're talking about. But then also, the education we can give them, the reassurance we can give them, we can help them build confidence in themselves, and that could truly determine, like, do they go down that chronic pain route, or is this something where it's like, oh, all their fears are reassured, and then we steer them back to recovery. And so this is a cool diagram that I saved. Occasionally we'll bring out.
Yeah, no, that's awesome. Thank you actually for sharing that. Yeah.
Good job.
Thank you.
We got less than a minute left, so if anybody has any other questions, we can also save a little bit of time after Tommy's, but we can move on to Tommy's presentation. But yeah, good job, man. That was awesome.